I think that was brilliant. Thank you. Urmil, could you also expand a little bit on some of the challenges that very critically unwell patients, when they transit from mechanical ventilation, especially when they are ventilated for many days, with no recourse to a center with advanced ECMO facilities, simply because of the volume of patients desirous of services that are limited to very few centers and very few geographies, given the fact that there are very few air charters that are available to be able to transfer these patients, given the fact that there are so many guidelines for transferring patients who are COVID from one state to another, the state bureaucracy, then given the fact that you're looking at multiple teams trying to work between each other with no experience of working together in the past, how do you probably look at all of this coming together eventually in a transfer of a patient to a virtual facility that is probably able to take care of them, and the challenges that the treating team would face in those initial few days with dealing with myopathies, steroid overuse, multi-drug resistant infections, non-conscious patients simply because they were on a vent with great amounts of sedation, and a great deal of mental, what would I say, degradation of many of these patients. And I'm sure Pranav and Ravi, who are with us, would probably throw some light on their personal experience a little while later. But I just thought that let's move some of the clinical work to begin with, so that we can set a stage for a more broader human discussion. So any thoughts on that, Urmi?
So I think practically there are two challenges. One would be the clinical challenge, and other would be a logistical challenge, considering the pandemic situation. Now, clinically, as we have prolonged mechanical ventilation, patients on ventilatory support for more than 10 days. Sometimes, I mean, what we have seen as compared to the first wave and the second wave, the first wave, the referrals were pretty late, more than 10 days, 15 days on mechanical ventilatory support, and then being referred for higher tertiary care, whether it is ECMO or transplant. As vis-a-vis as the second wave, I think there was a lot of awareness among the medical fraternity, and the referrals were pretty much earlier in the maybe in the first week of the acute lung injury. Now, as the days goes on mechanical ventilatory support, there is a lot of the diaphragm muscle weakness which starts creeping in. There is disuse atrophy, or the diaphragms become weak. There is neuromuscular weakness unless until the patient is undergoing a aggressive rehab there in the referring hospital. There is critical illness neuropathy. That means the upper muscles, upper limb muscles, and the lower limb muscles become weak, and patients are not able to even move their limbs against gravity. It's total weakness. There are repeated infections because they have been on prolonged ventilatory support. So repeated episodes of sepsis or higher antibiotics, antifungals being given. It's a post-COVID scenario. There is a viral because of the post-COVID scenario, the immunosuppression because of the post-viral illness is profound, and maybe post-tocilizumab, which is the drug given, and that's why we had these repeated infections. Plus, maintaining a prolonged adequate nutritional support is very important. If that is not maintained, the proteins levels drop in the body, the fluid starts getting accumulated. So these are the various clinical challenges which the transplant team also faces when the referrals come pretty late, and even those challenges have to be faced by the treating teams there till the patient is optimized for even transfer to a higher tertiary care. As far as the logistics part is concerned, I mean, patients on mechanical ventilator support with high oxygen requirement, the patient just cannot be transferred just on a ventilator. So for that, if the high ventilator requirement is there, maybe there is some kind of BP support medication is also required. There is a basic need to initiate ECMO there locally, which a transplant team or a third party has to do that, and then only the patient can be airlifted to a tertiary care center on an ECMO support. So that is a logistical challenge which the families usually face, where they have to understand about what is the ECMO or what is the ECMO, how it has to be initiated, why it has to be initiated, why the patient cannot be airlifted on mechanical ventilatory support. And obviously, considering the pandemic situation where the chartered flights are also available in lesser volume, again the cost of initiating the cost of airlifting the patient from one center to another center also multiplies. So I think you have logistical challenges, you have clinical challenges which also have to be troubleshooted before we think about airlifting such patients.